Dear colleagues, it's great to be part of this update program, and I'd like to thank Dr. Tom for this opportunity. My talk is on TAVI in low-risk subjects. Over the past decade, TAVI has evolved to become the treatment of choice for severe symptomatic aortic stenosis in the elderly. TAVI procedures outnumber TAVR cases in most Western registries. The risk classification of severe aortic stenosis is based on surgical risk scores. The most commonly used are the STS and Euro scores. Low risk is generally defined by an STS or Euro score less than 4. The largest population suffering from symptomatic aortic stenosis are actually low risk patients. So recently there has been an increasing trend to offer TAVI to low risk subjects. This trend derives from the non-inferior results of TAVI observed in recent large and well-designed intermediate risk trials. In the partner trial, TAVI was associated with lower deaths, lower strokes, lower major vascular complications, less atrial fibrillation, and early recovery with a median duration of hospital stay of about 3 days. In the intermediate risk TAVI trial, TAVI was found to be non-inferior to surgery. So in summary, RCT showed that TAVI is associated with lower strokes, lower deaths, less atrial fibrillation, faster recovery, better hemodynamics. TAVI is also less invasive and better tolerated in cases of instability. So these differences allow for TAVI to expand its role beyond the traditional ones. So what do the guidelines say? For high and prohibited risk, TAVI has a class 1 indication. For intermediate risk, it's a class 2 recommendation. So let's take a look at some of the low risk trials. So what is the definition for low risk in trials? For most trials, it is an STS score less than 4. For the Evolute low risk trial, it was a predicted risk of mortality less than 3 at 30 days as per heart team assessment. One of the earliest data on low risk patients came from the Notion trial. Notion trial was a randomized non-inferiority trial comparing TAVI and SAVR in 280 patients. 80% had an STS score less than 4 with a mean age of 79 years. There were no significant difference between TAVI and SAVR at 1 year, but the pacemaker rates and the rates of moderate aortic regurgitation was significantly higher in the TAVI group. In the German Gary register of about 20,000 low-risk patients, the hospital and 30-day survival was higher for TAVI patients. Recently, the results of the Partner 3 and Evolute low-risk trials were published. Both were multicentric RCTs comparing transfemoral TAVI with last generation device in SAVR. The primary endpoints differed across both trials. For Partner 3, the primary endpoint was a composite of death from any cause, all stroke, or rehospitalization due to valve or procedure-related causes at 12 months. In comparison, the primary endpoint in the low-risk Evolute trial was all-cause mortality and disabling strokes at 24 months. So these are the salient baseline characteristics of both the studies. The mean STS score was 1.9. The mean age was similar at 73 and 74 years. The primary composite endpoint was lower for TAVI in both the studies. TAVI was associated with a significant lower rates of atrial fibrillation, but the rates of pacemaker was found to be higher for TAVI in the Evolute trial. In the Partner 3 trial, all-cause deaths were numerically lower for TAVI. They also had lower rates of stroke and rehospitalization. Major bleeding and acute kidney injury were also lower for SAPIEN 3 TAVI group, but the rates of new onset left bundle branch block was significantly high. There were no difference in other endpoints such as coronary obstruction, endocarditis, reintervention, or valve thrombosis. There were no significant differences with regard to paravalvular regurgitation or effective orifice area. As I mentioned earlier, in the Evolute low-risk trial, TAVI was found to be non-inferior to SAVR for the primary endpoint. CoreValve achieved a numerically higher aortic valve orifice area. TAVR group had low risk of disabling stroke, bleeding complications, acute kidney injury, and atrial fibrillation. A recent meta-analysis of all RCTs on TAVI across the entire risk spectrum showed a reduction in mortality and stroke rates. So can we offer TAVI to all aortic stenosis patients? There are issues that need to be settled before TAVI can be offered to all patients. Concerns are, is evidence strong enough? What about the durability in a younger population? What about valve thrombosis? Is TAVI cost effective in younger population? What about anatomical and operator experience? What about asymptomatic patients? So let's take a closer look at the low-risk trials. Partner 3 had an unblinded adjudication of endpoints. This could have led to some bias in outcome assessment. The trial included a highly selected population. It excluded patients with bicuspid aortic valves and poor transfemoral access. The follow-up period was limited to 1 year. Addition of rehospitalization to the composite endpoint made it a weak endpoint. High incidence of rehospitalization after SAVR is well acknowledged, and this was the main reason for superiority of TAVI over SAVR in the first year of the trial. The Evolute trial failed to emphasize that only 10% of patients actually reached a 2-year follow-up. They had imputed data from patients with less than 2 years and combined with those over 2 years using a novel Bayesian analysis. So who were the study participants? They were patients at low surgical risk with ST score less than 4. We know that current risk scores have limitations. They were developed for surgical populations. They do not account for rare conditions. Many variables are not captured, for example, frailty. Definition of risk factors lack precision. They do not account for operated or hospital experience. So were they really low-risk patients? Patients selected were actually at low risk for suboptimal outcomes after TAVI. They were suitable candidates for the transfemoral route. They had high coronary takeoff. They were tricuspid valves. There were no severe aortic annulus or alveolar calcification, which means they were highly selected patients, and they may not be representative of the low-risk real-world population. So what about the age? The mean age was a half a decade lower. Lower risk does not imply lower age. So what about durability and structural degeneration? The data for durability are not strong enough because most studies are around for 6 to 8 years only. The rates of structural degeneration seem to be similar for SAVR and TAVI valves at 6 years, being about 7%. We know that pericardial valves start to fail after 7 to 10 years. At 10 years, the freedom from structural degeneration is about 72%, and it drops down to less than 50% at 12 years for surgical valves. So this is a graph showing average survival for an individual born in the US. It may be lower for us, but we could make a little bit of extrapolation. For someone at 60 years, the life expectancy is about 20 years. So let's take an example of a 63-year-old with severe aortic stenosis. He gets a TAVI at 63 years. 9 years later, his valve fails. He requires a valve-in-valve procedure. If the first valve is supraannular, then there is a risk of coronary obstruction. Redo TAVI will result in increased gradients and give suboptimal results. 5 years later, at 78 years, he experienced valve degeneration. He has developed additional comorbidities. He is now at high risk. Surgeon is not happy to operate. What do we do? So unless there is a long-term data of more than 10 years, there will always be concerns on durability. TAVI, especially self-expanding valves, are at high risk of permanent pacemaker, which brings in added cost and morbidity, including risk of lead infection, endocarditis, and left ventricular dysynchrony. Bicuspid valves were largely excluded from large randomized trials of TAVI. Challenges for TAVI in bicuspid valves include heavy eccentric calcification, elliptic aortic annulus, abnormal coronary takeoff, and horizontal aorta. They're also at high risk of annulus rupture and aortic dissection. TAVI with early generation devices were associated with more frequent aortic injury, higher rates of AR, vascular complications, more frequent conversion surgery, and significantly lower device success. There were no differences for AR with newer devices, but procedure success rates were low and pacemaker rates remained high. Finally, the issue of valve thrombosis. The incidence of subclinical leaf thrombosis is as high as 40% with some valves. For some patients, it has been associated with neurological events. So in conclusion, are we ready or are we too early for TAVI for low-risk patients? There are major hurdles to widespread diffusion of TAVI in low-risk patients. The challenges are unknown valve durability in a younger patient population with higher prevalence of bicuspid valves that were not included in trials, higher rate of vascular complication, leaflet thrombosis, permanent pacemaker, and AR rates compared with SAVR. So therefore, I feel that we should not be too opportunistic about the low-risk trial evidence. Short-term data from trials may not be sufficient to support TAVI in patients with longer life expectancy. Without data on long-term results of TAVI in younger patients, it's perhaps too early to offer them TAVI. Heart teams are even more important now in order to make the best decision for an individual patient. So TAVI for low-risk patient is actually about learning who not to treat. Thank you.